we don't see the 60-year-old, 70-year-old bicuspids. We treat the 85-year-old bicuspids. So I'm going to give a little my perspective and so what we've learned, and I think probably the people in the audience could tell me a lot more than I've learned because I think you have a lot more experience with bicuspid valve disease, but it has a component of bicuspid patients. And so this is a propensity matched analysis from the TVT registry. It was almost 100,000 patients of SAPIEN 3 cases, and they found about about 2,700 matched pairs of bicuspid and tricuspid valves. And they matched on a lot of factors. It's a retrospective analysis, but there were low rates of complications like annular rupture, or second valve or stroke. They were higher. Although they were low rates, they were higher in bicuspid patients compared to tricuspid. And that's important to keep in mind. But this is a retrospective analysis. It's a site reported analysis, and it's a selected patient population. It's site-reported outcomes, and it's limited follow-up. We have 30-day data and 1-year data, and that's it. So we're not going to get any data about durability from an analysis like this. But what they did show, at least at 1-year mortality, they were comparable between bicuspid and tricuspid. We looked at 1-year stroke. They were, again, matched bicuspid and tricuspid. Relatively low rates, 3% at 1 year. And paravalvular leak in the two groups was relatively low. You look here, rates of moderate PVL at 1 year were 3% in the bicuspid, 2.5% in the tricuspid, no different. And overall, relatively low rates. The caveat being this is site-reported, not core lab echo, is important consideration. Mean gradients, again, relatively matched between the two groups, no significant difference between the two groups. And this was a balloon expandable SAPIEN 3 analysis, not a core valve. But there's a lot of limitations, and we've had the same analysis with core valve, but there's selection bias. These are patients that were felt to be appropriate for TAVR. It's not all bicuspid. So you don't know what patients they selected, degree of calcium, things like that. These were patients all that were still felt to be higher risk for surgery. These are also patients that probably did not have an aortopathy because otherwise they would have had surgery. And again, from an endpoints, there's no CEC and no core lab. But it is data suggesting that they can be treated, as you have seen here, and with the live cases, they can be treated safely. But so if we are treating bicuspids as are being done here, what are the considerations when you're choosing a THV in bicuspid valve disease? Obviously, we had these discussions earlier, annular size. Key components of a TAVR is you got to get seal, you got to expand the valve to optimize hemodynamics, but you also don't want to cause root injury or cause a pacemaker. And so things like a heavily calcified raphe and the root size can impact that. And those are important considerations and be relevant in the consideration of type 1 versus type 0. And so fundamentally, and this is to Marty's talk earlier, this is where we can get better with AI and modeling. Because we need to understand the interaction between the TAVR device and the native complex. And that can be modeled. Again, unlike surgery, we're not removing the valve. And so these are things that we have to consider as what is that interaction going to be? Is it going to expand? Is it going to seal? Where is it going to seal? Is there room? And right now, we're doing that in our own minds, whether modeling with FEOPS and other computer programs, algorithms can make that better is an important question. So, as I said earlier, the CVIS classification was really historical, and this may be more relevant. This is looking at the type of calcium, raphe or no raphe, and these are what's relevant when you're talking about doing a TAVR valve. And so you see the majority of patients, at least in this analysis, or bicommissural raphe type. I think in India it's different, probably much more what we've seen here is type 0 or the bicommissural non-raphe type. So these are important considerations when choosing a valve type. And the reality is calcium patterns vary. Whether if it's rheumatic disease, more fibrotic potentially, or even in non-rheumatic disease, you see patients like on the left with sort of fusion and fibrosis with less calcium, and you see patients on the right with more calcium. And I think these do matter. The location, eccentricity, and the things I worry about more is when there's eccentric calcium. When things are symmetric, I feel like the expansion of the valve is more controlled. When it's eccentric, and that's what bicuspids present, there's more shift of the valve in terms of where it sits in the root. And so patterns of calcium are very important. And so fundamentally, we're talking about preventing PVL. So when we talk about TAVR, historically we talk about the annulus, and we measure a single plane in the annulus. And we talk about that as the seal zone. The reality is the seal zone is not one point on the valve or one point in the LVOT. It's along a long segment. But we measure at this annulus level. But when you're having a bicuspid, sometimes we talk about the seal zone at the leaflets, because if the skirt seals at the leaflets and you circularize at the leaflets and it seals, then you're going to not get PVL. And we saw that in that accurate case that was done earlier, where the valve was at 0 on the annulus, but the seal occurred on the leaflets in that type 0 valve, and that's what prevented the PVL. But the skirt has to cover the seal zone. We do deploy high if the seal is occurring at the leaflets, and you need to take into account leaflet height. So when we're sizing here, we need to take several things. And the first one is really an anomaly. The raphes don't crack, but we always talk about it, right? But is it not that it cracks and it splits into a tricuspid, but does it lift up? Or is it going to be a rigid wall that's going to prevent expansion in that whole direction? And you got to think about where will the seal occur, and what is the root morphology? Are the sinuses symmetric or asymmetric? Is there room for the native leaflets in the root? And so there's a lot of different sizing algorithms, and I don't think there's one that's right. And it may be for different anatomies, and I'm just going to highlight it. The Bavard algorithm was mentioned earlier, and I think people are often referring to it. And it looks at the shape of the valve and the relationship of the intercommissural distance to the annular dimensions. And so if you have a tube-like shape or a flare where the LVOT is smaller, you just use the annular size. It's what's recommended by this method. However, if you have a taper where the LVOT is larger and the intercommissural distance is smaller, then the sizing is done using that intercommissural distance, and you may downsize. The rationale here is, even if the LVOT is big, if you try to expand to the LVOT and you don't have room at the level of at the commissures, that's where you cause injury. So the rationale is that you sort of downsize at that point. So you're measuring at the different levels. And these can get complex because, again, the interoperator reproducibility of these measurements is really variable. Whereas at the annular measure, it is much more reproducible. Then this is the Casper method, which, again, it seems way too complex when you look at it. And I won't go through all the algorithms, but basically, again, it's taking into account the raphe, calcium, and on all of these methods are trying to understand what is the interaction of the valve with the raphe and what is the risk of injury. This is the Lyra method, which I think is the most prone to error in my opinion, because again, you're measuring up at that level of the leaflets. There's a lot of variability. Smoothing algorithms will make those measurements different when you're looking at perimeter, and especially if it's very irregular. But again, this is using the concept that the seal is occurring much higher and not at the LVOT, and not to oversize too much, because if you do, you risk injury at this level. And in some ways, the simplest method is the circle method. Basically, put a circle similar to a sapien or MyVal, whatever dimension you're going to use, and it's really just right if the circle extends to the commissures. And if it's too small, it's not going to reach the commissures. If it's too large, it extends beyond the commissures. And again, all of these, we got to be better, and I think things like FEOPS and other things are going to be better at modeling this. Right now, all these algorithms are doing are trying to model in our heads what these valves are going to sit and what they're going to look like, which is hard for us to do 100%. But these are the main considerations, and to me, it's really about injury that I worry about. And so if the raphe is calcified, valve expansion is not going to be complete. And so you may be not centered in the root, you may be distorted to one side. And so you might want to consider undersizing if you have a heavily calcified raphe that's going to prevent expansion. The calcification of the cusp are pretty significant. And if you have heavy calcium, we've done annuli and bicuspids of 800, 900, because the leaflets are so calcified, that's where the seal is going to occur. It's possible. And so you can think about that. And what was shown earlier, balloon sizing is a useful option in some of these patients. And doing a 22 balloon, as we did earlier today, without leak, reassures us that it can be a good option. I'm just going to go through a few case examples quickly. These are very different types of bicuspids, right? This is a patient case that we did, annular area of 350, not much calcium. The sinuses were reasonable size. And so, in some of these patients, I think what's relevant is seeing what the BAV balloon does. The BAV balloon really stayed central. There is no leak. There's no concern about the root, minimal calcium. I felt it behaves like a tricuspid valve. So in this, a 23 sapien did fine with really minimal leak. And this is obviously an older example because it's an older generation of a sapien system, but this bicuspid behaves like a tricuspid, and there were no high-risk features. But, this is an example from, as presented at Jim, heavily calcified raphe are going to prevent expansion. And so you can see it's very asymmetric, it's very oval. Now this is a core valve. The leaflets should hopefully still should function, but this is a valve that you're going to end up trying to deploy high. The seal is going to be high. And also you may need to undersize this valve because of that heavily calcified raphe. And this is an example of mine where I didn't do that as much, but 29 core valve, that's the seal zone. We put a 29, and oh, these are playing here, okay. You look at how the valve looks. Now, there's no leak, right? We looked around, there's no leak, but the valve is very deformed in the sinuses. And the mean gradient is 13 for 29 evolute, which is pretty high. So we hemmed and hawed about this for a while. There's no leak, the gradient's 13. We elected to just dilate it with a 20 balloon. And because just the leaflet morphology concerned us, whether it would impact durability, I don't know. But you can see here now the valve is much more circular. It's still a little bit oval, but it looks better than it did before. And the mean gradient went from 13 to 5. Whether that was necessary or not, whether it impacts durability, those are things that we have to sort of answer. But radial strength matters. These are cases where you can't do, right? And this is a patient that, we would send to surgery. If you're going to do a valve, the question is what valve? And I think balloon expandable has radial strength. I think some of the self-expanding, especially supraannular, may function, but you need to aggressively predilate. And if you don't, you can have examples like this where it just won't expand and where it can be sort of catastrophic, so you got to be careful. So again, heavily calcified raphe, you get risk of contralateral, you get risk of contralateral injury. And so what we do, and this is not a great example, but during the BAV, I will look, and sometimes you'll see a poking into the root and really sort of observe that. But sometimes there are unusual complications. This is the one that I was surprised by. This was only a couple years ago. Annual area of 554, perimeter of 84. It's a type 1, large sinuses, 34. It's a non-right fusion. The left sinus is small. It's very asymmetric. The coronary heights, the left was around 11, the top of the left was around 15, and the right was around 12. So it was, again, an area of 554. We ballooned with a 26. We got a good seal. We elected to go with a 26 Sapien 3. We thought it was undersized and would fit well. You can see here, reasonable deployment, maybe a touch lower, about 3 or 4 millimeters low. But it's a fully deployed 26 Sapien 3. Right after, severe refractory hypotension, wall motion abnormalities, VT, VF, ended up CPR. And what you see there is you see no flow into the left main. And we're completely occluded. We ended up going on ECMO, and you see here, you see the outline of the left cusp. And you see that white line. The left cusp went up and sealed the sinus. Now, why would it do that? We had a sinuses of 34 and 35. You wouldn't expect that to happen. But we ended up getting around. We ended up putting a stent through the sapien frame, pushing the leaflet down. Patient came off ECMO and eventually ended up going home and did well. But you had to be ready to deal with it and had to ECMO. But if you look at why that happened, that raphe was fused. We model a sapien sitting there. It didn't sit there, because of that fusion. It was asymmetric and it got pushed to the side, and so it got pushed towards the left cusp. Then the left cusp was relatively high, but the sinuses were asymmetric, and even though it was 11, the left leaflet, if you do the curve measurement, was close to 15, and the sinus height on the left was shorter. So we had a long left leaflet, short asymmetric sinus on the left. The valve got pushed over, and by doing that, occluded the left main. So, there's some things that are sometimes hard to sort of predict and model, but you have to be aware and understand that. And, part of the question was what valve choice? I right now don't think any one valve design is better than another in bicuspids. I personally think in the future we're going to have to do leaflet modification to use our current TAVR devices, and that's going to be the better solution, whether it's like a basilica procedure to tricuspidize the bicuspid to allow symmetric expansion or something else, I don't know, but I think that's where we're going to go for the future. And so it's all in valve choice in bicuspids is a risk-benefit calculation, as it is in tricuspids, where you're balancing hemodynamics and PVL with risk of root injury. And there are a lot of considerations that we talked about. Degree of calcification, which is going to relate to valve expansion, and you need to factor in the radial strength of your TAVR device. The pattern of calcification is really relevant for the risk of root injury. The valve morphology, whether it's a minimally calcified type 1 or a type 0, will determine the location of your seal. And annular size, and all those will still relevant for looking at paravalvular leak. I'll stop there, and thank you very much.